Hello, my name's Katie Stevens, and today I'm going to do a presentation about a recent paper which we've written for the American Journal of Obstetrics and Gynecology, entitled Group B Streptococcus and the Risk of Perinatal Morbidity and Mortality Following Term Labour. Group B Streptococcus is known to colonize the vaginal and gastrointestinal tract in 10 to 30% of women. Outside of pregnancy, this is a commensal bacteria and is not associated with any harm. However, in pregnancy, Group B Streptococcus is the commonest cause of neonatal sepsis. Maternal colonization is the primary risk factor for neonatal sepsis. Early-onset GBS disease accounts for around 60% of neonatal infections and presents within 7 days of birth and occurs secondary to vertical transmission during labour and delivery. Early-onset Group B Streptococcus sepsis in the newborn is associated with a risk of neonatal death and also moderate to severe long-term neurodevelopmental impairment. As you can see from the figure on this slide, the highest incidence of early-onset GBS sepsis is seen in sub-Saharan Africa, and within this population, the babies are also at higher risk of long-term neurodevelopmental impairment and death. In a high-income country, the presence of Group B Streptococcus in the maternal vagina is associated with a small risk of death and severe disability if there is no intervention. As demonstrated in this figure, if we take 10,000 pregnant women, around 2,000 of those women will be colonized with Group B Streptococcus. Of those 2,000 women, 50% of their babies will become colonized, which gives us 1,000 babies which are colonized with Group B Strep. Of those 1,000 babies, 10 to 20 will develop neonatal sepsis, which results in 980 to 990 having no clinical sequelae despite being colonized with Group B Streptococcus. Of those 10 to 20 babies with neonatal sepsis, 0.8 to 1.7 babies will die, 0.8 to 1.7 babies will have a severe disability, and 8.4 to 16.6 will have a full recovery. Apparently, there are many different strategies for screening for Group B Streptococcus across the world. In the US, Canada, New Zealand and Australia, a universal screening approach is adopted where all women are screened for GBS in pregnancy using vaginal or rectal swabs. Due to GBS colonization being intermittent, transient or persistent, the recommendation is to screen near the time of birth. In the US, this is between 36 and 37 plus 6 weeks using a vaginal and a rectal swab. Intrapartum antibiotic prophylaxis is then indicated for those women who screen positive for GBS to reduce the risk of early onset neonatal sepsis. However, despite this approach, there remains a lack of level 1 evidence that a program of screening and intervention for Group B Streptococcus reduces the risk of neonatal sepsis. In women without a penicillin allergy, it is recommended that a penicillin-based antibiotic is the first-line choice, such as benzyl penicillin. The antibiotic choice is more difficult in those women who have a known penicillin allergy due to increasing resistance to tetracyclines, erythromycin and clindamycin, as demonstrated by this slide. In those women with a reported penicillin allergy, it is recommended that they are offered allergy testing in their pregnancy. Those women with a true penicillin allergy, the choice of antibiotic should then be based on sensitivities in the GBS culture taken at the end of their pregnancy. Group B Streptococcus is a known cause of antepartum stillbirth without rupture of the fetal membranes. However, a study in 2019 demonstrated that Group B Streptococcus may have a more common antenatal sequelae than stillbirth. A 2019 paper looking at placental metagenomics included the analysis of 79 placentas delivered by prelabor caesarean section at term with intact fetal membranes. This study demonstrated that Group B Streptococcus was the only endogenous bacterial signal detected in the placentas. Interestingly, this was quite a common finding, with Group B Streptococcus being found in 5% of placentas. The clinical importance of pre-labor invasion of the uterus by group B Streptococcus, if any, remains to be determined. So in summary, group B Streptococcus can be associated with a risk of neonatal sepsis, stillbirth, and we know that around 5% of placentas are colonized with group B Streptococcus antenatally. However, we still don't know the clinical sequelae of this. Group B Streptococcus is also associated with an increased risk of maternal sepsis in pregnancy. In conclusion, group B Streptococcus is the most common cause of early-onset neonatal sepsis and is associated with the risk of neonatal death and long-term neurodevelopmental impairment. However, adverse outcomes associated with group B Streptococcus remain uncommon. Very large numbers of women need to be treated with intrapartum antibiotics to prevent each case of neonatal sepsis. Pre-labor invasion of the uterus by group B Streptococcus is of unknown clinical importance and requires further investigation.